in Spain, how the health system and the hospital react to the pandemic, what change we have in the orthopedic and trauma practice, what about COVID-19 and surgery. We have some research on this and some suggestions based on our mistakes. So, background, as you remember, by mid-February in Spain, we don't have cases, just 2 imported cases from Germany in the Canary Islands, so quite far from Spain, and there were only 2 main outbreaks. As probably also you do, we thought that was not going to reach us, but you can see cases in Madrid. By 2 weeks before, in March 6, we have 200, and then very quickly, 1 week later, we have only in my city 3,000 more. Most of the Madrid population were confined at home. But as probably you see in your country, that takes a long time to stop the numbers. So 10 days before, we have in Madrid more than 16,000 cases. And 1 month before, 5,000 cases only in Madrid, with more and more deaths. But at this point, we managed to flatten the curve. And you can see in the next month, we changed only from 50,000 to 66,000. So the major increase in patients were in the first month. You can see here our curve. You can see that it takes about 2 weeks of total lockdown to decrease the number of patients. So we have like 250,000 cases with almost 30,000 deaths, but I must be honest, we don't know exactly the number of deaths because in the first weeks we cannot have exact information of all the patients, but in the last week we only have 7 cases in the end of case about of the problem. If you don't take the protective devices and also hospital beds, and even as if we have 38 hospitals in Madrid, with many ICU beds. We have 600 ICU beds in the city for 6 million inhabitants, and we had to double the ICU total capacity. So we 100 beds to 1,200 beds.
Okay.
We create new ICU areas in, for example, in rehabilitation areas in the hospital. And even with that, we have for 2 weeks a very restrictive admission criteria for ICU. So for 2 weeks, only patients below 65 were admitted because we don't have really more space in the ICU. And also for non-critical patients, we create a 1,000-bed hospital in the Madrid Exhibition Center, and 12 hotels were converted in like hospitals, not really for severe patients, but for non-severe patients. So finally we have a space for all of our patients. This is the exhibition center in Madrid with 1,000 beds. We did that in about 2 weeks, so it was a great effort. So one important person. So from our point of view, most trauma doctors in my unit, for example, got infected in the first weeks, and most of them in the outpatient clinics when protective measures were not implemented. So what we've seen in Spain is that once you have good protective devices, it's quite difficult to get infected. It's possible, but it's difficult. With adequate protection, contagion in health personnel is not so common. Now we have data in Spain. All of the personnel in my hospital have the test now after 3 months, and only 10%, between 10% and 15%, depending of the service, got infected. And that's important. I think also, apart from get protected, it's very important to treat every patient as an infected one, even when the curve is going down, because now we are seeing in Spain a lot of small outbreaks. So for example, we have one today in my unit. We detect one patient admitted 1 month ago, and they became positive. We don't know how. So it's very important to treat every patient as if they are infected. This is my hospital. We have 1,100 beds, including maternity and pediatrics, 4 ICUs and 3 post-op recovery rooms, and 32 operative rooms. We have our first patient with coronavirus admitted in February 15th. We didn't know at that time. We knew that later on. And you can see, this is by mid-February, but 1 month after that, this is the news in Madrid. This is collapse in the emergency at hospital 12th of October because of coronavirus. So the problem in Spain is that we have no time to prepare, because we were really the 3rd country in the world with these big outbreaks. Probably you have more information than we have, but in the first weeks, what happened to us. So you can see here in the left side, the number of patients admitted. We have almost 900 admitted patients in the hospital. So most of our beds were dedicated to COVID. I don't know if that is the situation at your countries now. We have about around 100 patients in the ICU in our hospital. And you can see here in the left, here down, almost 20 deaths daily at our hospital. So that is in the worst weeks of the pandemic. Mm-hmm. So how we deal with this overload? Well, we turned all the operating rooms into ICUs. We closed all the operating rooms. We did our trauma cases in the external OR. Also the rehabilitation gym turned into ICU. All wards in the, you can see the main building, the orange one, were dedicated to COVID patients. And in the worst day, we have almost 1,000 patients admitted. And non-COVID patients were transferred to the maternity and pediatric buildings. Well, what we do as trauma surgeons at our hospital, because that's a problem. We don't have much work. So in my case, in my hospital, the youngest doctors below 35, because they are at less risk of getting infected or getting severely ill, assist internal medicine wards. We also create prone teams in ICUs because it's a heavy work to turn down twice a day 100 patients in the ICU. So the trauma surgeons make teams of 3 doctors just to prone patients and to put in supine position. Also, we did phone information to relatives, and we try to maintain clean and COVID wards. That's, I don't know if you have this problem, but in Spain, we didn't do this early. And if you don't do, if you don't do this very early, it's very, very difficult to maintain clean and COVID wards. So that must be done early from the beginning. Well, what can you expect if the pandemic hits hard at your site? I don't know what's your situation now. I think it's not very well, but I don't know if it's so bad as in Madrid. But in my experience, at least 2 weeks of continuous increase of COVID patients, because it takes 2 weeks of lockdown to reduce the number of infections. In Madrid, the ICU saturation came 15 days after the outbreak. That's a problem because it's a long time. The contagion in health personnel inside the hospital occurred during the first 2 weeks, most of the cases. And finally, we dedicate 80% of the hospital capacity to COVID patients. And also, another finding in Madrid is that a big number of hip fractures in elderly patients came to the emergency with pneumonia on admission. So we have both problems, COVID and hip fracture. We did some research about this. We have published in the British Journal. I will show you later. So how did we change our practice? Well, we closed all the elective surgery because it's dangerous for the patients. They can get infected at the hospital. It's dangerous from doctors, and more important, you will need the beds and the OR and the postoperative recovery room for COVID patients. In trauma, probably it's the same everywhere. We back to the basics. So we operated only trauma, big trauma, hip fractures, polytrauma, some articular fractures in young patients, but most upper limb fractures were treated non-operatively. And also, it's important to note that with the lockdown, we have a great decrease in trauma admission. So normally we have maybe between 5 and 10 admissions a day. And during the lockdown, sometimes we have 1, sometimes we don't have any admission. And of course, malignant tumors and infection, especially if they are life-threatening, you have to treat it. So I think there are several studies. This is this is very interesting because it's the first study. This is from China, probably some of you know. They found that when you operate a patient during the incubation period of the COVID, the complication rate increases a lot. So you can see that in that study, the patients with surgery in the incubation period, 44% needed ICU, and the mortality was 20%. And this group is not hip fractures, it's everything. So it seems from this study, I don't know if in the future we can have the same numbers in other hospitals. Operating patients during the incubation period is very dangerous. So if you have a patient with a positive PCR for coronavirus, it's probably wise to wait until 2 weeks to see if the patient developed the disease or not. Also, this is from China. They found also that in older individuals with hip fractures, the prognosis is bad. This is our study. This is the first publication with the first 124 patients. Now we have a database with more than 1,000 hip fractures, and we will publish probably by the end of this month. But in this study, what we see is that in the patients with COVID, the mortality rate was about 30%. And in the non-COVID patient, about 10%. And also what we see is that in some patients, delaying the hip fracture fixation for more than 2 weeks was a good measure. So in some patients with pneumonia and hip fracture, it's probably a good idea to wait until the patient recover for 2 or 3 weeks and then operate, even if we know that this is not the best for the hip, but this is the best for the patient. So for hip fractures, in patients with hip fractures and COVID, we found high mortality. I think in patients with pneumonia, it's better to wait until the patient recovered than trying to operate early in order to get the patient out of the bed early. And there are some different studies about this. There is also a study from New York with very few cases that recommends operate very early. I think with our data, we have a large number of patients from 20 hospitals in Spain. I think it's very dangerous to operate patients during the COVID infection. Also, we found a large number of hip fracture patients infected on admission, and some of these patients had asymptomatic pneumonia as CT findings. So not always symptomatic, the pneumonia. This is very important. I think it's not only the clinical evolution of the patient, but also the radiological findings in the thorax. So in Spain, what could we do different? Well, as we were one of the first countries in the world with this big hit of cases, we have some failures. So we failed to protect the elderly, especially in the nursing homes. So half of the deaths in Spain were in the nursing homes. That was very, very, very bad. We should have started the lockdown earlier. You must protect all personnel and all patients in hospital from the beginning, so don't wait. You have to shut down external outpatient clinics very early, and also all elective surgery. As I said, you need both the personnel and the beds for COVID patients. It's very important to keep clean areas in the emergency area, also in the wards, and it's very important to do that from the beginning, but because once you have all the patients mixed, it's very difficult to create clean and COVID areas. And another idea, we didn't manage to do it, is to keep isolated trauma teams. So one team works 1 week and the other team the next week, so you avoid contagion of the whole service. What did we do well? Well, in Spain, we had a very strict lockdown in the whole country for 2 months, and I can tell you that it works. Now we don't have deaths. We have 1 or 2 daily, but very, very few deaths. We managed to double our ICU and hospital capacity in 1 month. That's very difficult. We managed to decrease the infection in health personnel after the first month. And that, I think, is also important to maintain a COVID and non-COVID OR from the beginning. That, of course, depends on the hospital you are working. So in summary, my best recommendation is to anticipate. Probably in your country is different because you have some time to prepare. You must close outpatient clinics and elective surgery early. Most trauma patients can be treated non-operatively. It's very important to maintain COVID and non-COVID areas in wards and in operative room. And of course, if you can, but this is not always possible because the lack of test, it's very important to test every admitted patient. Now we, even as if we are in the flattened part of the curve, we test every patient admitted at the hospital. So I think that's all I want to show you. We can now.
Thank you, Dr. Pedro. Thank you very much for an excellent presentation. It's really a nice experience to share it with us. At this moment, we have the rush of cases. It's like your peak. I have questions from participants. We receive it during registration. Do you have any increase in musculoskeletal infection during the period of the COVID-19?
No, no.
It's almost the same.
Notice that. The same.
The second question regarding the hip fracture, the incident of it, is it increasing during the COVID-19 or the same incident? As you said, you have.
We have less cases than normally, so probably half cases.
Half cases.
That we have normally. I think one of the problems is that patients in the nursing homes probably didn't reach the hospital. So
okay.
if they have a hip fracture, probably they died at the nursing home because maybe half of incidents.
Okay. Regarding the how you deal with the malunited fractures for upper limb or something like that, because you said you all manage the upper limb trauma with conservative treatment. For example, like both bone forearm fractures in adult, how?
Well, I think humeral fractures, you can treat it most non-operatively without many problems. So for elbow and forearm, we don't have really, I think we have 2 or 3 cases and we operated. And for distal radius, I think we treated conservatively. It's not, it's just 3 months. I think we will see the complications probably at the end of this year. But I must say that we didn't have so much complications. No, we don't have many.
Okay.
We have forgot to treat patients non-operatively. You can treat a lot of trauma injuries non-operatively.
Yes. Thank you very much, Dr. Pedro. Now to the next presenter, Dr. Bader Al Marboui, the guideline for operation in positive case COVID-19. You can share your screen now, Dr. Bader. Yes, it's coming.
Hi, good evening, everybody. I hope my voice is clear.
Yes, it's clear.
Yes, thank you very much. First of all, I would like to thank everybody who's attending this. And I would like to thank Dr. Saleh for organizing all this, and he's inviting me to come to talk about the experience which I'm going to share with you. I would like to thank Dr. Pedro and for an excellent talk and excellent lectures and sharing the experience in Spain. We know that in Spain, the number of cases much more than us, but I hope everybody soon is going to be safe. Now, I'm in charge of the orthopedic department here in Buraimi Hospitals, and at the same time, the assistant director of medical affairs and the in charge of operation room committee. So when we start receiving a patient with COVID, immediately came in my mind, if we have to operate a patient with a COVID positive, what we should do, what is the proper steps, and what is the guideline which is going to follow. So it was always coming in my mind. And actually, very soon after we started admitting patients, we received one patient who had intertrochanteric fractures. We tested him and came as COVID positive. Unfortunately, fortunately, he doesn't have a major symptoms related to COVID, and this is why he was fit to be operated. So I thought before starting this operation, I have to go and find the guidelines which helping me to treat the patient and how to make patient safe and our staff. My concern was the surgeon, the staff, the hospitals, and the patient at the same time. So if you go and see the literatures, you'll find so many guidelines, and most of these guidelines, actually, you will find it 30 pages, 40 pages, 45 pages, which if I'm the in charge, I may read it. But whether my members going to read it, the staff nurse, is the radiographer going to read it? Is the cleaner going to read it? I don't think so. So I have a meeting. I sit with different departments, including the physician, the staff nurse of the operation theaters, the infection controls, anesthetists, surgeons, and we try to come with a guidelines which can be accepted by all according to our situations, according to our facility. And actually most of our hospital, like any other hospital in Oman, almost we are sharing the same facility, more and over. So I said, before starting this case, I need to plan it well. I need to make sure that all my team's member who's going to share with me the surgery, they know all the steps which is going needed to be taken and all the guidelines that they should understand it. So I divided these guidelines like steps of the guidelines, which is before surgery, what we should do, during surgery, what we should do, and after surgery, what we should do. And I'm sure with each time doing, we are learning more and more experience, and we are trying to correct ourselves. So on that intentions, I sat with all the, before starting the case, I discussed the case with the anesthetist, the physician, the operation theater, and never forget the infection control department in your hospital. Believe me, they will help you a lot. So we decided, like always, keep enough PPE set, that the whole set in one bag for each member. And we said we keep at least around 8 ready at any time in the operation theater, which can be used even in case if you have to take a patient to the emergency. One important thing I want to tell that these guidelines, not just only for an orthopedic surgeon, the same guidelines can be used for general surgeon, for gynecologist, for ENT, whoever. But we are, so before taking any patient to make sure that a full PPE set available in the theaters, discuss and inform the OT and concerned department. Don't surprise even the cleaner or radiographer that while you are in the theater, you call them, I need radiographer. No, make sure that all the team members know that. Now, very important things is how to do proper donning and doffing, how to put in your equipment and how to remove it and where to remove it and what are the steps of doing that one. And believe me, there are so many short and very scientific and videos which are available even in YouTube's, and infection control department in your hospital will going to help you on that one. So make sure that all the staff involved in the surgery, I'm insisting including the cleaner, because if one member doesn't know how to do it, he may spoil the whole things. Make sure how they know. And just before starting my surgery, I had a meeting with the member to those going to say, I show them a video exactly how to do donning and doffing. Second things, make sure that when you do the surgery, you don't need an extra unnecessarily stuff. Probably it's not the time for example, somebody to learn. It's not the time for the resident or medical student so try to minimize also the number and make sure that this surgery to be done by a senior surgeon, senior anesthetist around. So at least the operation theater and operation time is going to be less. So something very important here. I'm sure you will have a minimum of one anesthetist, probably two surgeons, one circulating nurse, one anesthetist nurse, probably one radiographer, one cleaner, and make sure there's one circulating nurse outside the operation theater, and you have a direct phone contact with her. So when you want anything while you are operating, instead of calling somebody going outside, going outside, you can, through duct phone, contact this nurse who's circulating. And if you need something really from outside the theater, she can help. And she is to consider one of the members and she has to put full PPE. If the case is not emergency, then try to do it when no or a minimum other cases going on in OT. For example, in our case, it was our weekend is Friday and Saturday. So we admitted this patient on Wednesday. You routinely and usually we do the surgery the next day, which is Thursday. I said, no, we'll do this since it was the first surgery. We will do it on Friday, although it's a weekend. Why I choose Friday? Minimum number of no other cases was in theater, minimum number of staff including in the theaters. Remember one thing, spinal, regional or local anesthesia are preferable in such cases. We as an orthopedic surgeon, especially most of our lower limb surgery, we can do it either spinal or regional anesthesia. And if this is why, for example, upper limbs or general anesthesia has to be done, make sure, and this is also the message to the anesthetist, that bacterial viral filter to be used. And after the surgery, the anesthetic circles and the sodalim has to be changed. So during surgery, specify an OT which use a specific OT, you can use it. And in our setup, luckily we have, suction negative theater. And it is preferable you have a negative pressure theater do the surgery. And we choose our, like, the closest theater, which when you direct the patient from the ward, the nearest theater which going to minimize the contamination with the other operation room as possible. And always after, call the patient only when your operating team is ready with PPE. The patient should not come while you on your team are not ready with not wearing their protections, because here is our priority is the team safety. And we prefer to use, along with all other PPE, N95 mask. Although now, like the national guidelines, only you need it with air arousal procedures. But I feel our members' protections is very important. We need to protect our surgeon, our staff. So whenever possible, always keep a N95 mask. When the patient starts coming to the theater, only precise short handover through the phone. Then shift the patient directly to the operation room. We don't keep them in the waiting area before the surgery, so that we minimize the waiting area patient. Make sure that the patient always, whenever possible, make that the patient wearing the surgical mask all through, except if the patient condition doesn't allow the patient intubated, the patient ventilated, is a different issue. Second things, we notice that sometimes when you are in theater, you may receive unnecessarily disturb if you are bringing your mobile in. So no mobile inside the theaters, and use only the duct phone for communication, which you will get only the message through the hospital, not outside. Because the moment you are wearing full PPE, you cannot use your phone, as simple as that. Now, after doing the surgery itself, do post-operative monitoring and recovering in the same operation room. Don't take the patient to the recovery room and do your recovery there. So you are, you may involve the two rooms, but no, try to make your monitoring and recovering in the same OT. Don't shift the patient from the OT till the receiving team, who is coming from the ward, has physically arrived. So the moment they receive, so directly they can take the patient to the ward. Now, if it's the surgery involved as a histopathology sampling, especially in gynae, or if you are taking, transport the histopathology sample separately in a double biohazard bags and inform the lab, and make sure that the porter is wearing gloves. Believe me, all small specific things, if you don't look for it, you will get surprised that people do it, that doesn't do it in the right way. Now you ask and instruct your nurse to wash the instrument in the sink of the same operating room. So this, because you may expect that the instrument is also get infected. Soak the instrument in the HAZTAB solution, and this concentration is according to the infection control protocols. Make sure that your infection control protocol is involved, and the nurses, they know exactly what is the concentration. For 10 minutes, then rinse with the water. If you then transport to the CSD in hazard bag and close CCCRD box. So now my take home message. Number one, plan. Failure to plan is a plan for failure. If you did not plan well, believe me, you will stuck with all problems. Make sure that all your team members are aware of the guidelines, and everybody knows these guidelines and they know what we should do exactly. Second things, be flexible, and you can modify your plan according to the situations. But always keep in your mind your team safety. So what I did actually, to summarize all this, and instead of having 35, 45 pages guidelines, and guidelines. So with this one, everybody going to read. Everybody, you can easily print it and keep a copy in the Word. You can keep copy in the theater. You can keep. So everybody going to read it when it is a single paper. But if it was now in this single paper, this summarize all my talk. Very easy to be followed up and very easy to be read. But if you give him 35 pages, 45 pages, believe me, nobody read. Thank you very much. Any questions?
Thank you, Dr. Bader, for your nice and precise presentation with the steps. You are already answered the questions which has been asking by the participant during the registration. Just we'll see any question now. The question from Dr. Dinesh. What type of PPE you use for COVID patient to be operated?
If you see this photo, this is our, actually we are using, I mean, overalls, and inside that one we are using the X-ray protection because this surgery was involved. We need to have to use CM, and we use N95, and there's something and shield cover. Now it is a very important thing when you use N95. Some people, they use N95, then they put a surgical mask, then they put shield. We found it is very difficult to operate with this three. You will find a lot of fogs. You will find, you will not be, and even not just only fog, you will find a lot of water, and you cannot tolerate it, and you will not be able to see. But if you use just N95 and the shield without the second surgical mask, it is still possible. And actually, if you see, I mean, this was, in the middle, it was me. On the left side, my assistant staff nurse. She did that when she put a surgical mask, and then she was probably scared. I told her this is not needed. Once you use an N95, you didn't need another surgical mask, but she put it. But believe me, during the surgery, I can see her face full of water. So my recommendations, use an N95 and the surgical shield on top of N95, or actually the guidelines, if you are not directly involved with the air arousal, because I know some countries when patient has to go under general anesthesia, only the staff nurse, I mean the anesthetist and the staff nurse will intubate the patient. They will wait half an hour because with the negative suction of the theater, then the surgeon will come. Probably if you are following that one, maybe even a surgical mask without N95, always possible. It is very important to protect yourself. And we know that N95, like the penetration for virus and for bacteria, it is very, very minimum. So your risk is very, very minimum. One important thing I want to tell also, especially when you remove your PPE, remove all the PPE inside the operating theater except the N95 mask. You have to remove it outside the theaters. Any other question?
Yes, we are happy about your operation guidelines. Dr. Hafiz, he asking about your orthoclinic guideline as well. If you have, you can share it.
Definitely, this is not. It is for everybody. If anybody want to share these guidelines, I can send it. No issue.
No, he asking about the orthoclinic, not about the operation. Orthoclinic guideline as well. It's
orthoclinic. That will be the next. We can make it in the next webinar.
It seems you are very good in the guidelines to write it in precise and formative way. We have a question from Dr. Hamad Al-Hinai. Why you exposed and stuff with a surgery? Why exposed you and stuff to a surgery which can wait for
Voice.
Dr. Bader?
For me?
There is a question for you, Dr. Pedro.
Which one? Polytrauma?
Yes, from Dr. Wael Hijab.
Yeah.
Hello.
Yeah, we don't find increasing rate of osteomyelitis of septic arthritis during the epidemic. Is the same or less? I can see another question about polytrauma. Well, with polytrauma, what we did is we prepare sets of external fixators with a drill, some pins, some bars, some clips, just to put it inside the ICU. So you don't have to get the patient to the OR. So for example, a patient with both femur fractures, we just perform external fixation inside the ICU, and you wait until you are completely sure about the clinical condition, both polytrauma and COVID.
Okay.
If the patient is COVID, probably the best thing is to wait for at least 2 weeks to see if the patient develops the worst illness.
Okay. Dr. Bader Al Marboui.
Yes.
Can you hear? There is a question from
Yes, yes.
Hamad Al Hinai. He said, why you exposed you and staff for a surgery which can be wait for 2 weeks? This is a common question for a positive case patient who needs surgery.
Again, what's the question?
Why you exposed you and your staff to a surgery which can wait for 2 weeks? That means what's the urgency to do surgery for a patient?
See, this patient. See, as I said, this is one of the early cases which we have. Patient had not much really symptom related to COVID, and he has intertrochanteric fracture, painful, even he was on a loan, and you cannot send him home. At the same time, you don't need to keep him in the hospital with all the possible complication, where you can operate with a very small risk, I will say. If you have the proper guidelines, you are wearing and you are taking all the precautions, believe me. Now I'm working in this hospital. We have now for the last 4 months, and the same problem, some like similar guidelines we are having for the COVID ward. Not a single staff, thanks God, not a single staff was infected from our COVID wards. Now, if you say why you are exposing your staff, I am exposing my staff for surgery in 2-3 hours. But what about if you keep this patient in the COVID ward, you are expecting the staff for another 2 weeks. So which is more risky? Is to expose your staff for 2 to 3 hours extra and operate, and next day the patient was discharged, or you keep the patient for 2 weeks in the COVID wards and you are going to expose your staff nurse who's working morning, afternoon, and night. Actually, you'll expose more people and for a longer period of time than if you operate such patient.
Okay. Dr. Pedro,
Yeah.
There is a question from Dr. Hafiz Rehan regarding any specific PPE you are using in the ortho clinic. How to protect yourself during the clinic?
Yeah, during the worst part of the pandemics in Spain, we didn't have outpatient clinic, so we only see some wounds reviews and something like this, but all of the patients, we just phone them. Now that we start with the outpatient clinic, we keep a place for COVID patient. So we interview the patient outside the clinic. If they had symptoms or if they had previous disease, we see those patients in a specific place. Patients without symptoms and without doubts we see normally, but just with a mask.
Okay.
So that's all.
I think we answer all most of the question. Dr. Bedr, do you have any comment to Dr. Bader Al Marboui guidelines or anything insight from your side? Dr. Pedro?
Sorry?
Do you have any comment to Dr. Bader Al Marboui guidelines?
Guidelines.
Yes.
Well, the problem with guidelines, we at first we have plenty of guidelines, but I agree with Dr. Bader that this 30 pages, and the other problem is that change very quickly. So we start with one guideline and we change every single week. So I'm not sure about the guidelines. So probably the best thing is to have very few clear ideas of what you can do at your place, because every hospital is different. I think in Madrid, all the hospitals are working differently, depending on a lot of things. So probably the best idea is to get, like Dr. Bader said, a few very clear points, because you cannot control everything. Everything changes week by week. You don't know where you're going to be in a week. You can be the same, you can be worse, or you can be better. So be flexible.
Okay. Dr. Bader Al Marboui, do you have any comment and experience from Spain?
Yeah. See, first of all, regarding the guidelines, as I said, that it is according to the setup of each hospital. You're right, Dr. Pedro. And second things, I said that was my first sentence. It's according to our setup. And my last sentence was, I said, be flexible and you can change it according to the situations. Yes. With time, we are learning. COVID disease, for us, it's still a new disease. There's so many secrets of it which we are not learning, and each day we are learning new things. And when you made guidelines, revise it to improve it, yeah. But according to the situations.
Okay,
regarding now, I would like to thank Dr. Pedro regarding his talk. It was an excellent sharing of the experience. We know that Spain probably the third country which has hit hard, and thanks God they managed really to come out of it. Their curve now is coming down, and their normal lives start to be gaining back and going to the normal life. Wish them the best. Wish all the health care works and the whole health population that we get out of this pandemic, and hope everybody's in a good peace, healthy, wealthy, and thank you very much, Dr. Pedro.
Dr. Pedro, just one last question.
I like the word Dr. Pedro and Dr. Bader. It's very nice, very clear.
Yeah, it's difficult. It's difficult. Yeah.
Pedro and Bader, very nearby names. We can become friends.
Actually, Dr. Pedro, the meaning of Badr in Arabic language is mean full moon. So this night we have 2 full moons from Spain and 1 from Oman.
2 full moons.
Yes.
Okay.
So I guess I have last question from Dr. Sultan Al-Maskari. He said, Dr. discussed some surgeons in Spain suggest delaying surgery to reduce the inflammatory response.
Yes.
And this will be the last question.
That's the research we did. We get data from 20 hospitals, many data. So now we have about 1,300 cases of hip fractures. And what we saw is that if you operate the patient between contagion and the start of the illness, it seems, this is difficult to prove, but it seems that the surgery can develop inflammatory response. So my recommendation with the data we have is patients with COVID on admission with pulmonary symptoms or with pulmonary thorax alteration on X-rays, I think you should wait until the disease develops completely. So some of these patients recover very early, but some of these patients, if you operate, they can die because of the response. So I think you must be very cautious in these patients, very, very cautious, okay?
Okay. Thank you, Dr. Pedro. Too much gracias for you to sharing your experience and your country to our society. We are delighted. And inshallah, we'll meet again in the next webinars. Thank you, Dr. Bader Al Marboui from Buraimi Hospital.
Welcome.
Thank you, all the who participated with us and who asked questions. It was very nice with the 2 full moons. Thank you again, and have a good night. Thank you very much.
Thank you very much. Hope to see you soon.
Inshallah. Thank you, everybody.
Thank you. Bye.
Bye.